It's minimally invasive unless the patient is opted for open heart surgery, and we'll do a surgical AVR. But pretty much on our aortic valve, our patients that are candidates for the position now, for the valve, they have what we call aortic stenosis. So they have sclerosis around their aortic valve, so it doesn't open and close all the way. So normally, if our patients, they come in, normally we have tri-leaflet valves, so we have 3 leaflets. Some of our patients have congenital bicuspid valves, so it's 2. Normally, if they have a congenital bicuspid valve, they will be a candidate for this procedure along their lifetime. So then we look out to see, is it a congenital or is it more of a calcification over time? We've had patients that don't have any type of, distinct heart history where they just have a bad valve, and normally that's your bicuspid valve. These are just kind of like the stages. So now we are doing, we only implant for severe to critical aortic stenosis, but we watch these patients. So if we see that the patient has a moderate, I'll keep them on my tracker, and they'll eventually get to this within a year, depending on how good they're taking care of themselves, and some of them aren't even taking care of themselves. But we don't usually catch patients, unfortunately, till they're here in severe, and they have chest pain, dizziness, syncope, fatigue, shortness of breath is usually our huge one, dyspnea on exertion, and what else? Or, like I said, syncope, and then they'll have even back pain with it as well. So, but that's the symptomology. There was that. So, but I'll send this to you. Next time I can do a better one. So with this patient, for example, he's already had an echo. That showed us primarily that we had aortic stenosis. We look at the EF as well there. On the echo, we'll look at the valve area. So anything less than 1 centimeter square is a candidate. We look at the mean pressures and the mean gradients and the peak pressures. They have to fit within a certain range for me to say, yep, we can go forward with this patient, or no, we have to wait. They don't meet requirements. And then we also look at if they have any type of regurgitation in other valves, whether it be the aortic valve, the mitral valve, or the tricuspid valve. We look at their max velocity. That has to be over 4 milliseconds. So all these things that are on the pre-workup, we look at, so we can say, hey, this patient's a candidate. We'll look over it with all the physicians, and then we look at access, etc. So that's our step 1. We go through a heart cath, so you'll see heart cath being done before. We check their coronaries, because if they have left main issues or LAD issues, then we can definitely put this patient in a permanent block, or they can die on the table. So we need to make sure we correct that first before they can actually go for the aortic valve replacement. We'll do what we call a 5-meter walk with our cardiac rehab with our cardiac rehab team. If they can't walk, like this patient's on pressors, then I'll send for a dynamometer exam, and they'll just do a grip strengthening exam. We have to be able to measure how frail they are. So, and I can look at labs, but most likely their albumin is, yes, it's low, but that's not enough. So I need to show how frail they are. We also do a CT angiogram of their chest. So you'll see, if I say we need to order a CT angiogram, it's CT of the chest and pelvis. So that way we can check the vessels, because we go in femorally. And then we also use the chest CTA, so we can size what valve size we're going to use. And it'll also help us look at maybe if the physician wants to figure out which valve we use. So we have 2 different vendors that we use. We use a Medtronic valve, and then we have an Edwards valve. This is a self-expanding valve. It'll self-expand over 24 hours. This one we typically try to use if the EF is super low, if it's less than like 20, because we don't want to burst pace them to like 180 beats per minute in the operating room while we try to expand this balloon. So in this diagram here, you can see where this is an Edwards valve, and what we do is it comes in and it's crimped together with like a 16 French sheath. I think the biggest one is a 14 French sheath. So it's a big old hose that we put. That's why we'll use a manta, or we use a perclose to close that leg. But the way this happens is that it comes in crimped. We push it through. We start burst pacing the patient at 100 beats per minute while we're inflating the balloon. So the native valve, the valve we were born with, gets pushed to the side, and this one, if you can see that there's some yellowish things on the side, we need to have some calcium in the aortic valve in order for those little, they're microscopic hooks kind of thing, they grab onto the calcium and that's where they sit. When the patient comes out of the procedure, normally we'll have like a temp pacer to the left, and then most access is to the right, just because of the way the room is set up. If the right iliacs are not good, we'll go to the left side. So we'll always know that part. So if you get a slide from me, because the patient's going to come here for any such reason, it has all of this pre-workup on one designated patient slide. It's not HIPAA compliant, so we're working on that. I didn't say that. But it has the echo, it has the heart cath, it has our CTA results, it has the patient's history, what their symptomology is, who was the surgeon that said that it was okay for them to go ahead and have a Tavr versus the Tavr, and then what device we're using and what size and what approach we're going for. So it has all that consolidated on the slide. Post-operatively, what the patient goes through is obviously they have a bed rest of 6 hours. They cannot move that leg at all. What I usually will get on, especially with A3, because that's normally traditionally where the patients go, is that as soon as that bed rest is up, my patient needs to move. They have to move. They're at high risk for PE. We've had that happen before because the patient didn't move for about 24 hours till the next day. So the patient has to move as soon as that bed rest is up. I usually say, I tell the patient's family members as well, make sure they get you up, they get you to the side of the bed at least to sit up and eat dinner. After that, you can sit back down, and then the Foley should be coming out. Hopefully, we try to take the Foley out when we come out of the Tavr, but if they come with the Foley needs to come out as soon as the patient's off of their bed rest. The pacer may stay in if the patient blocked during the procedure, or if the physician just says, leave it, take it out in the morning, you guys can discontinue it in the morning. So that's completely fine. It's just an extra precaution in case you need it. The next morning, cardiac rehab has to come in and eval. So, and it's on our order sets. I brought you guys a copy of our pre and post-op order set somewhere. Anyway, so what needs to be done in order for your patient to get discharged is they have to have cardiac rehab come and eval. They are really good about calling me and telling me, hey, this is what our recommendations are, or the patient didn't do so well. Or the patient did fine, and they're now saying you can, from cardiac rehab standpoint, patient can go home. The patient gets an echo at 24. It has to be done in the morning at 8 o'clock. They'll get an echo. We'll take post-operative measurements and to make sure that the valve is still sitting where it needs to be sitting. And then at that point, the interventional cardiologist will come by, they'll check the patient, I'll come by, do discharge instructions, and then at that point I'll tell you the patient can go home. So length of stay wise, the patient should be going home next day, and we always look for trying to get that patient home before 1 o'clock. So that's our goal. We do really well with meeting that, because the cardiologist will come in first thing in the morning. So these are the instructions that I usually give the patient, and they're all out for you. So like right now, A3 is doing one for me because I'm a little bit late right now. But anyway, so everything's just there for them. So they get a white folder. That was the white folder I was looking for. And what I include is a temporary device card. It has the serial number of the device that's on there. If that folder gets lost, I can't replicate that card. They will get another one in 3 months. That is because once the device is registered nationally, it goes through a national registry. But it takes them 3 months to get a card. If for any instance they don't have the temporary, then just make sure you have an updated physical address for them or mailing address so that we know for sure that's where the card's going to go. But as far as any discharge instructions, they need to see their, we call them ICs, or interventional cardiologist, the person that does their procedure, or if it's the cardiologist that belongs to their clinic, like say it's Dr. Taylor that's doing it for Dr. Damaraju, or that usually doesn't happen, but if it's Dr. Taylor doing it for Dr. Schechter, then they can see Dr. Schechter because Dr. Taylor can look at the stuff. Like, so they need to see them at least within the first 30 days. I always like for the patient to be seen by someone in 2 weeks, But they need to see the IC's office at least within the first 30 days because they have to have another echo done. Okay. At that point, the patient gets reevaluated again at a year. And again, it's EKG, labs, and another echo. And then I will also follow up with them at a year. I go an extra step and I follow up with them at 2 years. So, because we put everything in our database in our registry. So here I put, this is for the patient. So this is something they can hang on the wall. It gives them a place to put their post-operative appointments and the date that they had that echo. It has to be, because anyone that receives this has to go forward with the workup after, because if not, then it wasn't a complete case. And then this just tells them how we take care of them for the following 2 years. So on here, the big things that I usually make sure that I tell them is that for the first 3 days after their Tavr, while they're awake, every hour on the hour they have to get up and try to walk around a little bit, and then they can sit back down. So that's to decrease our risk of a PE, okay, or DVTs, but mostly PEs. The next thing I hone in on is the dental visits, because all the bacteria in our mouth want to go to the valves of our heart. For the first 6 months, any dental visits that they have to get antibiotics for. Doesn't matter if it's even the cleaning. So most of these patients, if they have poor dentition, we have to get dental clearance pre-operatively. I don't have many of those. But if they do have poor dentition, I get a pre-op clearance from their dentist. And then of course it goes over potential problems as far as like bleeding at the groin or infection. And then I make sure, because this always comes up and I always get a call or a text after that, can I shower? Yes, we want you to shower. So what I always tell the nurses is keep that Tegaderm dressing on, the original one, because it's sterile underneath. I like for you guys to border out any bleeding that's on that, so that way they know that if the bleeding exceeds those borders, they need to call someone, whether it be me, whether it be the IC's office or a PCP, or just come straight to the ER. And then after about 3 days or so, I tell them if it's falling off, take it off. If not, soap and water, pat dry, no ointments, no lotions, no Bacitracin, no Neosporin, nothing should be going on that. Soap and water only, pat dry, including if it's the Tegaderm still intact. So yeah, because they need to make sure that they wash all the way around on the groin. Let me see what else. Obviously, if they stop urinating, and you guys know this, if they stop urinating, because we need to get that contrast and anesthesia out of their system, they need to keep hydrated, not more than enough water, but just enough to where they're peeing. If they stop peeing, or they just feel like they're not urinating as much as they're actually intaking, they need to call, because we need to run labs and check their kidneys, because we don't give them a lot of contrast, but we give them contrast.
Do you know how much normally?
Normally we give like about 30 to 45 cc's. It just depends on
That's
how.
really good, actually.
Yeah. I have had some physicians actually give up to 100, but it's because either they're having trouble placing it, or it's a MitraClip where we're just spending a lot of time in there looking for placement. But usually it's about 30 cc's. It's not a lot.
Do you do IV hydration after like 100%?
We don't, because a lot of these patients are in heart failure already. We don't want to encourage always giving just the IV hydration. We will finish what we started, but we want the oral hydration for sure. Yeah, but not more than what they need to be. Obviously, we need to make sure check for the heart failure, lung sounds and stuff. That's pretty much the gist of it. So, but again, if you have someone that's working with him for pre-op, it's just a matter of getting all his exams done. I'm watching the patient. Dr. Taylor already consulted me. I've already done education for him. And then we go from there, and then he will more than likely come back to your floor if he leaves. Who wants to try that?